Hello, I'm Katie Whitaker. Welcome to the May edition of Audio Monitor. This month, HRT, a new therapy for the misery of menopause.
It's clear, colourless and virtually odourless and is in an alcohol base.
Addicts in Glasgow are benefiting from a GP drug clinic.
Putting into place schemes, systems of care that have been shown elsewhere in the world to be of value in helping to reduce the mortality and morbidity associated with injecting drug misuse.
In our clinical news review, a more accurate scoring system for assessing stroke risk. The fastest, most effective way of treating leg ulcers. How steroids can help slow rheumatoid arthritis. Who should be referred for endoscopy? And as always, more tales of the unexpected from GPs around the country.
When they got to the hospital, the ambulance was empty. The patient, in fact, had disappeared.
And a reply to last month's opinion slot defends the record of cooperative services, while this month's, controversial as ever, accuses NHS management of corruption.
You can't possibly have a view that differs from the government's view, or else you're thought of as being in the pay of Moscow. You must be a communist if you don't agree with current government policy.
First, our clinical news. A simple risk score totted up on a pocket calculator could be more effective in predicting strokes. The score, based on age, blood pressure and evidence of angina, was found to predict over 80% of strokes occurring within 5 years in high-risk patients. Research fellow Dr. Will Coppola of the Royal Free Hospital School of Medicine in London and one of the report's authors told me how useful he thought the new scoring system could be for GPs.
What we have shown here in our study is that combining risk factors is very much more powerful, and whichever of the individual risk factors one might want to look at previously, such as smoking or high blood pressure, while they do identify a reasonable proportion of strokes, they also tend to be very non-specific, whereas the score that we've developed is both sensitive and specific. So it means that we can identify a large proportion, namely over 80% of strokes, in a relatively small group of people.
So how do you envisage this system being used in practice in the surgery?
Well, it would be very much up to individual practices how they would choose to use it, but as it's fairly straightforward to calculate, it's something that could be done either by a practice nurse as part of a screening policy for patients, or by a GP opportunistically, and wouldn't necessarily require special or extra workload. It could be quite easily slotted into any health promotion activity that is currently ongoing in a practice.
Dr. Will Coppola, whose paper Scoring System to Identify Men at High Risk of Stroke was published in the April 95 edition of the British Journal of General Practice. And on the subject of stroke, a report in the April the 1st edition of the BMJ indicated an independent association between migraine and the risk of ischemic stroke in young women. Women under 45 with migraine were more at risk from strokes if they smoked or took oral contraceptives. The recommendation is that although their absolute risk of ischemic stroke is still low, young women with migraine should be advised not to smoke and to pick the lower dose oral contraceptives. New guidelines have been published on the management of chronic venous leg ulcers. The guidelines from the British Association of Dermatologists recommend compression bandaging and exercise as being the best treatment, although elevation to reduce edema with bandaging later is also recommended. No drug treatment has been found helpful, nor has any dressing of any type been found to enhance healing rates. Skin grafting should be reserved for failure to heal after a year's treatment. In a study in the British Journal of Dermatology, however, aspirin has been found to improve the healing of chronic venous leg ulcers. In a double-blind placebo-controlled study over a 4-month period, aspirin was shown to lengthen thrombin generation time and to increase ulcer healing rates, although just how it works is not known. Details of both the study and the guidelines can be found in the April the 12th and April the 20th editions of Monitor Weekly, respectively. New research suggests that steroids may help slow the progression of rheumatoid arthritis. A 2-year study showed that low doses of prednisolone halved the progression of joint damage and the number of patients who developed hand erosions. The study is said to be the first time treatment for RA has been shown to slow the underlying disease process. Dr. John Kerwin, the leader of the study and senior lecturer in rheumatology at Bristol Royal Infirmary, told me how he thought GPs should interpret these results.
Well, I think these results are an important step forward in understanding rheumatoid arthritis and how we can treat it. And I think GPs should interpret it as a new opportunity to help patients with established rheumatoid arthritis.
What about early rheumatoid arthritis? Is there any change of direction that GPs should take there?
Well, the patients that we had in the study were all patients who had been definitely diagnosed as having rheumatoid arthritis. But they were all patients whose diagnosis had been present for less than 2 years. So they were relatively early disease, but they were well-established disease and unarguable, if you like. And so we're not talking about patients who present with an acute polyarthritis that may later turn out to be rheumatoid. We're talking about people who have definitely got the diagnosis of rheumatoid, but who are in the early stages. Quite a lot of the patients in the study had not yet developed any erosive change. And one of the exciting possibilities with the use of the treatment is that it might stop erosive change from occurring in some joints. And this, therefore, will protect those joints for the future. I mean, at the moment, if you get erosive disease in rheumatoid arthritis, even if the inflammatory disease is suppressed, the damage that's been done to the joint may lead to secondary osteoarthritis development and continuing problems. But if we could stop the damage from even starting, then that would be really good for the whole of the rest of the patient's life.
And these results were presented at the British Society of Rheumatology in April. A working party has drawn up a set of guidelines for appropriate referral for endoscopy. Dr. Tony Axon, a member of the working party and consultant physician at the Centre for Digestive Diseases at Leeds General Infirmary, gives more details.
The reason why we set up this working party was because it was recognised that many patients were being referred for endoscopy, waiting lists were getting longer, and it was extremely difficult, therefore, for patients to get a good service. We felt, therefore, that as perhaps some patients were being referred inappropriately, it would be worth looking at the indications again and setting out some guidelines as to the people we thought would be able to benefit most from endoscopy.
And who would those people be?
I think that those which are very obvious, doctors will know about anyway.
And who shouldn't be referred?
Well, then we come to the grey area, and within the grey area, any patient over the age of 45 who's recently had an onset of dyspeptic symptoms or a change in dyspeptic symptoms, they should be endoscoped. Also within the grey area, that's say those with a non-specific dyspepsia, any patient under the age of 45 who is positive for Helicobacter pylori or who are taking non-steroidal anti-inflammatory drugs, they also should undergo endoscopy. Those patients where the general practitioner intends to use long-term acid suppression, which is of course extremely costly, we believe before embarking on treatment they should be endoscoped as well. So when we come to those within the grey area that we think they should not be endoscoped, they're essentially those individuals under the age of 45 who have had mild or moderate symptoms, perhaps of reflux, which have perhaps responded to simple measures, and those patients who are negative to Helicobacter within that group, we don't believe need to be endoscoped.
And you can find more details about these guidelines in the April the 20th edition of Monitor Weekly.
Top floor, going down. When blood pressure is elevated, you can control it and bring it down. 4th floor, antihypertensive Motens can do that. 3rd floor, Motens controls blood pressure, but it does so gently. 2nd floor, with a gradual onset of action, Motens cushions against side effects. 1st floor, antihypertensive Motens cushions the fall. Ground floor. Thank you. Okay.
Designed for simplicity in asthma, AccuHaler, a new breath-operated device from Allen & Hanbury's, easy to use and easy to teach, with a dose counter to aid compliance. AccuHaler, available as Flixitide AccuHaler and Ceravent AccuHaler. Simplicity you can count on.
Now for the first of our tales of the unexpected, and a worrying moment for Dr. Moira Bremicombe from Sheffield, who thought one of her patients was safely on his way to hospital in an ambulance.
A few hours later, I was phoned at the surgery. Much to my surprise, the ambulance man told me that when they got to the hospital, the ambulance was empty. The patient, in fact, had disappeared. I went back to the house, let myself in, and there he was, exactly as I'd first seen him, lying in bed in his pyjamas. So I asked him how this had all come about, and by now he was less confused and could in fact remember the story. And apparently he had decided halfway to hospital that he didn't really want to go to hospital, and the ambulance had stopped at a crossroads. He had opened the ambulance door, leaped out, closed the door behind him, and then ran over the fields in his pyjamas, let himself in and got back into bed again and went back to sleep again.
And from the case of a missing patient to a case of mistaken identity.
It's very embarrassing at times when you go to somebody's house as the doctor in your best GP-type suit and your black bag, and the patient in fact doesn't recognise you. And one day this happened to me, and I knocked on the door, and the man of the house came to the door and said, "Not today, love, we're waiting for the doctor." I said, "I am the doctor." "Oh," he said, "I thought you were the Avon lady."
Drug-injecting patients, once an inner-city problem, are now an issue for practices across the country. The practical difficulties of treating these patients can leave many doctors feeling isolated. But a new initiative put together by GPs in Glasgow is proving beneficial to both practice and patient. Dr. Philip Wilson was one of the first GPs behind the new scheme.
Most large British cities have a drug problem, and Glasgow is no exception. Between 1 and 2% of the adult population inject illicit drugs, and drug abuse has now overtaken trauma as the leading cause of death in young Glaswegians, while infections like hepatitis C are a time bomb for the health service. By early 1994, a group of Glasgow GPs who had been struggling to cope with injecting drug users in the isolation of their individual practices came together to discuss their problems. Dr. Tom Gilhooly was one of that early group, and speaking from his practice of Breezeblock Shell on the edge of Glasgow's Easter House, he stresses that simply discussing the issues with colleagues provided tremendous insight and support.
Well, those early meetings were very interesting and quite exciting meetings, actually. I think it was the coming together of an awful lot of people who had been isolated and had different experiences. And there was a common bond that we wanted something done in Glasgow. We were very well aware of the huge scale of the problem. And I think that there was a common feeling that the only way that the problem could be tackled in Glasgow was through general practice, because of the diversity of the amount of surgeries and the amount of patients that could be handled.
But the meetings quickly moved on from mutual support to the development of radical proposals for a new system, which they believed was vital to help Glasgow's GPs treat and support their drug-abusing patients.
Basically, what they said is we needed a common protocol that we could all follow and that would be easy to follow. We needed to draw in more of our colleagues into this sort of work. We needed to convince people that the current practices, the use of dihydrocodone and other drugs, was probably inappropriate for these patients and that they could be much better managed. And we also needed to get the health board and the pharmacists in Glasgow to support us with supervised methadone and with a payment, because this did represent extra work.
The proposals were radical, but with drug-related hospital admissions in Glasgow having doubled every year for the previous 4 years, from 200 to 1,600, the health authorities were ready to be convinced by their arguments. Dr. Laurence Buckman, the public health physician with responsibility for HIV and addictions, helped draw up the GP drug clinic scheme and pilot it through the health authority, convincing them that resources should be focused on GPs.
Most of the injectors in Glasgow are registered with GPs, and the GPs are in a position to provide them with their medical care. The problem in Glasgow is so widespread, and there are so many people, that it wouldn't be feasible simply to rely on a specialist service. And provided the GPs were given adequate support, it was felt that they could do a substantially important job in improving the situation.
The scheme, launched in May last year, meant that participating GPs have to agree to specific prescribing policies, which encourage agreement with local pharmacists to supervise the administration of methadone on the premises. They must provide counselling facilities for their patients and attend a training programme. They also have to provide audit information for each patient. The prescription of dihydrocodone and temazepam by participating GPs is banned, as the Glasgow experience has been that they're commonly abused or sold. Dr. Bob Scott, a former GP, now heads the Glasgow Drug Problem Service, which oversees the running of the scheme.
It's a recognition of a way of putting into place schemes, systems of care that have been shown elsewhere in the world to be of value in helping to reduce the mortality and morbidity associated with injecting drug misuse.
But would the new protocol be enough for Bob and the team to persuade more GPs to become involved?
Well, I think we went back to basics and demonstrated that preventing, diagnosing and treating disease was, as ever perhaps, a proper use of doctors' time and effort, and that in the context of the drug scene in Glasgow, that quite clearly was to reduce drug-related harm to health as the objective of the scheme.
As the scheme nears the end of its first year, Dr. Laurence Brewer says the feedback from GPs is that it's helped them to help their drug-injecting patients.
I've had conversations with quite a large number of GPs in the scheme, and many have been very positive about what a difference they've seen in a number of patients who previously had been very difficult to manage and whose health had been very dodgy indeed. And they're now seeing them gaining weight, looking brighter. Some of them are now back in employment where they haven't held a job for years, so the experience overall has been very positive.
Tom Gilhooly says that his experience and that of his colleagues on the front line echoes this.
The feedback I get from colleagues is that the problems that they were experiencing when they were looking after patients in the old way in the surgery and using different drugs which were probably not appropriate have all but disappeared for these patients, for these practices, that the patients are now easy to handle and that the patients who are motivated and are willing to be treated do very well under this current scheme.
The major beneficiaries seem to be the patients themselves. Patients like Andy, a 38-year-old Glasgow heroin addict with a 20-year history of injecting drugs. He's been part of the Glasgow Drug Clinic scheme for 2 months and says it's given him new hope after previously frustrating relationships with GPs.
Well, it means I don't have to go out stealing. Every day was like I had to get up in the morning, I'd have to go out thieving, begs. You've had the saying, beg, steal or borrow. I had to get money, a certain amount of money every day. It used to be every penny I got went in drugs. Now I can get and buy myself things, clothes, different things like that. You know, it's just a complete turnaround. I've got up in the morning, I don't need to worry about I have to go out and get a hit or a fix. I don't need to worry about things like that. You know, I can start thinking about other things. And as I say, it's just completely about turning my whole life. I was at the stage where before I went to get taken on with Dr. Wilson, I was going to bed at night hoping I wouldn't wake up in the morning. Now I'm beginning to get my life back slowly but surely. You know, I see a future.
Patient acceptability, that's the priority in antihypertensive treatment.
No, cardiac protection should be the overriding consideration.
Excuse me.
I hear you, but if the patient isn't keen on the treatment because of side effects...
Yeah, excuse me.
What's compliance compared with angina, LVH or a heart attack?
Excuse me?
Yes?
Yes. Securon SR combines good patient acceptability with cardiac protection. For hypertension, it's the therapeutic balance.
Pardon?
Securon SR combines...
Yes,
we heard that.
What are we arguing about then?
I don't know.
Lottery's not very British.
Oh, of course it is.
No,
it caters to the
not.
basic British greed.
Securon SR. For hypertension, it's the therapeutic balance.
With over 100 million prescriptions worldwide, it's no wonder Losec is taking care of more people every day.
A topical tip now from Dr. Stephen Kidman of Bournemouth, whose practice had the idea of sweeper surgeries.
One of us each morning and each afternoon does an open surgery where no patients need appointments to come to see us. They just turn up, and it means everybody will be seen on the same day that they want to be seen, and it stops the routine doctors being called out of surgery, which was one of our highest blood pressure risers that we could think of, and they work very well.
Thanks for that, and don't forget, if you have any novel ideas or advice which you'd like to pass on, you can phone or fax us anytime on 0171 482 2218, and that number is also on the audio monitor insert in the May the 11th edition of Monitor Weekly.
All right now, bad habits can be very irritating, and I should know, right? Not off. IBS is even more irritating, but unlike me, you can't just switch it off, all right? There's a unique approach that treats the whole problem, Fibergel Mebeverin. Fibergel Mebeverin treats both components of IBS, not off. It treats the pain with an antispasmodic and the irregularity with a bulking agent, not off. And with only one thing to remember, patients comply, all right? Not off.
Fibergel Mebeverin doesn't half-treat irritable bowel syndrome.
Not off.
It's not only in music
But power
and gentleness
go hand in hand.
In Arthroptech too, power and gentleness combine harmoniously together.
The power to relieve the pain and inflammation of arthritis.
And the gentleness that comes from built-in protection for the stomach.
Arthroptech. Power and gentleness. It's music to the ears.
Istin, a growing reputation for reliability in hypertension and angina.
Now, as you know, Audio Monitor gives you a platform for your views and opinions. This month we hear from Dr. Laurence Buckman, who practices in North London and is a member of the GMSC, who's given us the rather intriguing title of Corruption Within the NHS as the subject for his diatribe. I asked him exactly what he meant.
I'm very worried that language has been corrupted and that truth has been corrupted and that propriety has been tampered with so that the NHS can change into a new beast that the government would like to see developed.
Let's focus in first of all on the corruption of language that you're talking about. What exactly do you mean?
Truth is lies. We have a situation where the hierarchy of the NHS says that such and such is the case, and those of us who actually work within the NHS know that that's not true. And whenever we say it isn't true that, for example, more people are being treated, it's just a trick with statistics, we're told that we're lying, and that, of course, you can't possibly have a view that differs from the government's view, or else you're thought of as being in the pay of Moscow. You must be a communist if you don't agree with current government policy.
Are we talking about a difference in interpretation here rather than downright lies?
No, we're talking about lies. We're talking about where managers have to say certain things because they're paid on their performance, and they daren't come across with an alternative view because they know they'll be dismissed.
But have you concrete evidence of this?
Certainly. One good example is the patient's charter, where our manager colleagues are being leaned on to make sure that every practitioner in the country has a patient's charter up on the wall, and our local managers. So I even hesitate to say local managers because someone somewhere is going to hear this and they will suffer as a result. But our local managers have been told that if they don't get the number of charters up to 60%, they will suffer. Now, that's a rather ominous term that could mean anything, but probably means less pay. So they're going to make sure that we all have charters, and we've been encouraged to do something, to play a game, to make it look like there really are charters. So Mrs. Bottomley can say 60% of the country has charters.
This is beginning to sound remarkably like a conspiracy theory.
I wouldn't use the word conspiracy. There is without doubt an intention back at base, both at the NHS headquarters in Leeds and politically in London, to make the NHS appear in a particular way which isn't actually the case. More whatever it is than ever before, whereas most of us know it's less than ever before.
Now, you said you were going to talk about corruption. What we're talking here about is questionable, isn't it? I mean, is there real evidence of definite impropriety, definite corruption?
Yes, a remarkable local event was where a finance officer in a local trust, we discovered, had previously been dismissed from employment by a London borough for financial irregularity. And when money started disappearing in the trust, this particular person, it turned out, had emigrated suddenly.
But you're surely not saying that this sort of case is rife?
Whilst it's not rife, it's certainly remarkably common. We have computer scandals in several parts of the country. We have consultancy scams in various parts of the country. But these are not unique circumstances.
They're not unique either to the NHS, are they?
They used to be remarkably rare in the NHS because it was very difficult to award yourself a contract because of the checks and balances that existed, particularly because most health authorities were under the control of locally elected people, may I say of all political shades. That doesn't happen anymore. There is no independent public scrutiny of what goes on in health authorities. They are now unelected, often self-appointed quangos. And what is most impressive is how many people on those self-appointed quangos just happen to be connected with the Conservative Party. I liked it the way it was when we had party politicians publicly elected on both political sides, if you like, to these bodies. I was quite happy to work with well-balanced health authorities that did this. I don't like any politicians being involved in a closet way because you never know what they're doing and whether they're working to a hidden agenda. And the climate of fear amongst managers and health workers alike is such that now many of us who work in the NHS suspect our managerial colleagues of being politically motivated. And of course, because they're paid on performance, without doubt, they do have an eye to the political agenda, both the public agenda and the private one.
Well, look, if what you're saying is true, how can it be eradicated?
It will be very easy to have elected members back onto health authorities of a variety of sorts. It will be easy for Mrs Bottomley to issue a statutory instrument through the House of Commons, and then we could have local councillors back on these committees.
Dr. Laurence Buckman, who will doubtless follow our previous opinion slot contributors in eliciting nothing short of a deluge of support and condemnation from our listeners.
Imigran, making a world of difference in migraine. Now there's an addition to the Imigran range, new lower dose tablets. Imigran 50, recommended for sufferers who've tried OTC analgesics. Imigran 50 can cost as little as £4.95 per month. Imigran 50, a first-line prescription for migraine, a new way to make a world of difference in migraine.
Which new antibiotic would be suitable for a range of RTIs like acute bronchitis or otitis media? We asked Dr.
And just right for all the family, kids and grown-ups.
With only 1% diarrhea, because diarrhea is not very nice now, is it, lovies?
And it's one a day romping home ahead of QID with poor compliance failing to finish.
And the outlook for tomorrow, well, it's another 24 hours of antibiotic cover. Tune in to CDAX, an antibiotic with all-round advantages.
And the rest of Audio Monitor can be heard on the other side of this cassette. Since time immemorial, older women have sought a remedy to the hot flushes and sweats of menopause. Many women have sought salvation in HRT, where there's every indication of long-term benefits. Dr. Peter Stott reports on the estradiol gel, the new HRT therapy.
Hot flushes and sweats remain the main reason why women come to see GPs asking for HRT. And of course, there's a lot of good news about its longer-term benefits. But have you ever wondered why only about 1 in 8 women takes HRT for longer than 8 months? What is it that's putting them off? Well, when we asked patients, these are the kind of reasons they gave.
Well, people say you get tender breasts or you get swollen stomach, you can get nausea. I haven't actually felt that really much at all. I was feeling far worse before I went on them, quite honestly. And I'm used to taking tablets because I have to take a small amount for my blood pressure, so just felt, well, 2 more, what does it mean, you know? So, sort of, I've got into the habit of taking tablets at the same time every day. So that felt all right. Although to begin with I did think, oh, you know, one has to take them day after day, and what if you forget? And actually I haven't really thought about what if I forget, what happens then. I haven't even asked. We'll see.
Well, I've used the pill and I have used the patch. I think with the pill there is an inclination to forget to take it. Also, I personally found that I was getting some, I won't say pain in the legs as much as feelings of discomfort. So I went back to my GP and said, well, I would like to try the patch because I had read that you don't get first pass metabolism through the liver, and so it was just possible the side effects would be less with the patch. I've been very happy with the patch. The only thing is that if you're in the swimming pool or the gymnasium, it is very evident. If you're wearing a bikini, you can obviously see it, and of course that does label you as 50 plus. Also, it can come off in the bath. I mean, it isn't a frequent occurrence, but it has happened once or twice, and you have to put it back on again. But other than that, I've been very happy.
It's fear of side effects like these which not only put women off taking HRT, but also cause those who do start it to discontinue it prematurely. Symptoms like breast tingling, nausea and leg cramps make many women think that there's something seriously wrong with them, and they prefer going without HRT to coping with these anxieties. Improved counselling, which warns patients to expect initial but short-lived side effects, may improve compliance. Dr. Christine Pickard is a doctor and radio journalist who broadcasts on women's issues. She often receives radio inquiries about HRT. Many of the women who contact her have already tried HRT and stopped it, often after a very short time and on their own account without involving their GPs. They give a variety of reasons.
They're not terribly rational, a lot of the objections they have, but you just feel it's a sort of emotional thing. And then you say, well, look, let's try it for a bit and just don't worry about it, maybe try a lower dose and just see how you go. And then try and make them feel that however they feel, they can come back and discuss it, and it's not silly and it's not something that I'm going to kind of poo-poo. But just encourage them to get comfortable with it. But I think certainly the more different types of preparations, then the better, particularly for that small group of rather difficult patients.
Because increased choice of preparations may improve compliance, a number of innovative delivery systems have been developed. So, together with pills and implants, we now have several different types of patches and, most recently, a transcutaneous gel formulation of the natural estrogen estradiol. Margaret Rees is a gynaecologist from the John Radcliffe Hospital in Oxford who is involved in its development.
The new gel formulation is called Estrogel and is one of the most commonly used forms of HRT in France. It's a transdermal gel that is rubbed in every day, and it's clear, colourless and virtually odourless and is in an alcohol base. Most people will use the equivalent of 2 dispensations from the can, and in our experience the equivalent of that was used by about 80% of our patients. Some people may use slightly less, some people need more.
Estrogel comes in a dispenser from which a measured dose of gel is rubbed onto the thigh or upper arm every day. A template is provided to give patients some idea of the area over which it should be applied. 12 days oral progestogen is of course also needed for those women who have intact uteri, but as regards the estrogen, absorption via the transcutaneous route is relatively rapid.
We normally say if you have a bath or shower, have it first, then apply the gel, and then get dressed. The interval of drying is 5 to 10 minutes, so we normally say brush your teeth while you're waiting for it to dry. We would not advise for somebody to have a bath immediately afterwards, because that should compromise absorption.
Margaret Rees considers that Estrogel will complement patch therapy as an additional transcutaneous system, and that for some women it will have attractions over both pills and the currently available transdermal patches.
Some women find that a patch is visible, and to them and their partner it's visible that they're taking a form of HRT. Some of the women who've had patches before may have had skin allergies and have found better relief with the gel, because the rate of skin allergies is minimal, in the order of about 1%.
And here's one patient at least who also agrees that the new gel may have significant advantages.
Well, I think it will probably have distinct advantages over other methods, since it's obviously easy to apply. You're not having to take a pill orally. It's not noticeable to other people like the patch might be. And I think it will improve compliance, and the more people that take it. And it offers yet another method, so it will bring HRT more to the forefront again and give the patients a choice.
The increased choice afforded by the new gel formulation could well result in improved compliance and greater numbers of patients sharing the potential benefits of HRT. Margaret Rees summed up the potential for Estrogel when she said,
"The compliance in the women who come to see us regularly is excellent. We have had women who have tried it and have not liked it, but in general it is a good form of HRT."
And that sponsored feature was brought to you by Herx Roussel Limited.
Patient acceptability, that's a priority in hypertension.
No, it's cardiac protection. Hold on, you're both right. Secure on SR combines good patient acceptability with cardiac protection. It's the therapeutic balance.
Welcome to Master Challenge, and your chosen subject, Dr. Bones, is topical NSAIDs and anti-rheumatics. What is the brand leader for relieving painful inflammatory conditions of the musculoskeletal system?
Movolat cream and gel.
Correct. Which topical NSAID costs only £4.14 per 100-gram tube?
Movolat.
Correct. Of the many brands available on prescription, I've started, so I'll finish. Of the many brands available on prescription, which is the most widely used?
Movolat. It's the #1 choice.
Correct. You scored maximum points and no passes.
Remember, no Movolat, no contest.
Fibergel Mebeverin treats both components of IBS, not ARF. It treats the pain and the irregularity. Fibergel Mebeverin, all right? Oh, not a...
Fibergel Mebeverin. Doesn't half-treat irritable bowel syndrome.
Last month's opinion slot on the danger of cooperative services giving telephone advice had the co-op doctors foaming at the mouth. Take Dr. Jonathan Hamill, Joint Vice Chair of Thamesdoc, a cooperative of 165 GPs in the Surrey area.
GPs in their own practices have been giving advice over the telephone for many years. The GPs who've gone on to join our cooperative are really just continuing to do what they were doing before.
But the fact that nothing has changed doesn't mean that giving telephone advice is the preferred option, though, does it?
No, not necessarily the preferred option, but it is an option. And we find that our GPs are quite happy to give advice to certain patients. Indeed, when our patients phone the cooperative, they ask whether or not they would like to see a doctor or whether they would like to simply receive advice. We find that up to 40% of patients simply say they're only asking for advice.
But how can you be sure that the patient will tell you everything? They may say they only seek a simple piece of advice, but a visit, particularly if you know very little about that patient, may reveal a very different picture from the one they give you.
Well, I think our GPs are very experienced, and from experience, they find that if they ask the right questions, they will get the right answers. I agree one can never be 100% certain, but the answer to that uncertainty isn't to automatically visit everybody.
How much of this issue do you think turns on the growing rivalry between co-ops and deputising services?
There does seem to be a rivalry between co-ops and deputising services, and I quite honestly have never understood it. From my point of view, that we have never seen ourselves in competition with deputising services, but on the other hand, deputising services have certainly seen us as competition.
And if you have an opinion you'd like to air on this programme, or if you'd like to respond to our past slots, please ring or fax 0171 482 2218 anytime, and you can find that number in the audio monitor insert in the May the 11th edition of Monitor Weekly. More unusual tales from GPs now, and a puzzling problem for Dr. Tim Richardson, a GP in Epsom.
A young girl had been attending both myself and the paediatricians for some 2 to 3 years with a history of a recurrent feverish type illness. The suggestions were that it was a recurring flu, possibly a case of ME, and at first it was thought it might have been glandular fever, though this was disproved. She would have periods of settling down and remaining well, and then weeks again of symptoms. As is always the case where nothing specific is found, there was a suggestion this may be stress-related. Some 2 years into the illness, she had a sudden loss of consciousness for a short period and was admitted by the paediatricians. They thought that she had a gram-negative septicemia, as she was quite unwell. This prompted them to a far greater range of investigations, including a CT scan of the head and an MRI scan which followed. For some reason they also did 2 24-hour collections of urine to look at the VMA, and indeed they found this to be abnormally raised. There had been no previous documented evidence of hypertension, and the CT scan was repeated, this time of the abdomen, but revealed no suprarenal pathology. She was consequently referred to the Hammersmith Hospital, where further investigations identified a pheochromocytoma in her left low abdomen. This appears to have been not only an extremely unusual diagnosis for a young child, by this time a girl of 13, but the site of the pheochromocytoma was also extremely unusual. This was successfully operated on earlier this year, and she has made a full recovery.
More a matter of luck than good clinical judgment next, as a GP from South London recalls her first nerve-wracking week on the wards as a house surgeon.
First day I had to clerk in all the patients for the next day's major operating list. One of the patients was a chap who'd arrived before me with rectal bleeding. He'd been investigated, found to have diverticular disease, and I had to get him ready for the next day's operation to have this removed. By the time I arrived on the ward a few days later, I was beginning to feel I was getting the hang of being a house surgeon. I'd survived a major operating list, a night on call, and the senior registrar, who seemed a little hostile and not awfully happy about breaking in yet another houseman. I realised there was a lot of activity at one end of the ward, which turned out to be the crash team around the bed of my gentleman who'd had his sigmoid colon removed a couple of days earlier. The nurses told me that he'd had a massive rectal bleed during the night and unfortunately a cardiac arrest shortly before my arrival. Resuscitation wasn't successful, and after the crash team had left, the senior registrar and I stood at the foot of the bed. He seemed very thoughtful. He turned to me and in rather accusing tones said, "You didn't put him on subcutaneous heparin, did you?" before his operation. I was dumbstruck. I stood for a few seconds thinking, and then shook my head and said, "No, of course not. He'd had rectal bleeding." The senior registrar walked off, apparently satisfied and possibly impressed with my perspicacity. I stood on thinking it over a little longer as the full reality of the situation sunk in. It was quite true. I hadn't put him on subcutaneous heparin, but not because of any great clinical judgment on my part. It was because I'd completely forgotten all about this vital part of preoperative prophylaxis. I hadn't put any of the patients for that list, or indeed the following day's list, on subcutaneous heparin, and nobody had noticed.
And if you have any tales to tell, ring 0171 482 2218. And don't forget to leave your name as well as your message and contact number or address.
Arthrotech. Power and gentleness.
At a price that might surprise you.
It's music to the ears.
Must contact Earth.
Quick, get him to sick bay.
Doctor, shouldn't you take that cigarette out of his mouth first?
Will you let me finish? I was about to diagnose COPD.
Chronic obstructive pulmonary disease. Then logically you were about to prescribe Combivent.
Of course I was. Who's the doctor around here?
Well, as a Vulcan I cannot tell a lie, so I'm afraid...
Combivent. Salbutamol plus ipratropium bromide. A logical combination in COPD.
My lords, ladies, and gentlemen, with over 100 million prescriptions worldwide, it's no wonder Losec is taking care of more people every day.
Now to our resident philosopher-physician Michael O'Donnell, who this month has been uncovering some rare disorders.
I never knew that words could cause disease until I worked with Dennis Norden. For it was Dennis, of course, who first described the interpretative disorder known as literalism, a condition that can best be defined as a congenital inability to perceive words other than literally. Dennis, who is himself a sufferer, will tell you that when he sees a headline in the Financial Times, "Public Borrowing Down," he immediately asks himself, why are people borrowing all this down? Is it because more of us are stuffing our own duvets? And on the days when we recorded My Word, I would get the backlash whenever he'd been to see a doctor. He'd come into the studio and say, "Saw one of your lot last week. Told me to drink more fluid. Now, Michael, what else is there that I can drink more of?" I also had to field complaints about doctors who plonked their stethoscope on his chest and told him to breathe in and out, as if there were an alternative. And once, when he was being weighed during an insurance examination and stepped off the scales, the kindly doctor sought to reassure him by saying, "You'll be happy to hear you're the ideal weight for your height and sex." So next time in the studio, he had to ask, "Now, doctor, is there really an ideal weight for sex?" As you may have noticed, there's a lot of literalism about, and many of its victims are doctors. Edward Staines, for instance, who practices in Spennymoor, wrote to me in alarm last month when the Department of Health sent him a press release headed "Advice to Pregnant Women During Lambing." As a literalist, he hadn't the courage to read on. And was it pure chance, I wonder, that the evening before I got his letter, I'd had dinner with Ramendra Seth, an erudite Nottingham GP, who asked me to explain why farmers talked about cows being in calf, when to his literal eye it was clearly the calf that was in the cow. I'm sending each of them a used tenner as a gesture of sympathy, because I know just how infectious the condition can be. Indeed, after I'd spoken to Dr. Seth, I found myself admiring the sensible advice that pharmacists print on the labels of drugs they dispense for grumpy old fellows like me. Keep away from small children. Yet, despite the infectivity, I think we should rejoice in the existence of literalism because of the sunshine it can bring to the gloomier corners of general practice. I remember years ago when I was at a dinner in Colchester, a local GP arrived at our table late because he'd been held up in his evening surgery. Yet far from being harassed, he was all aglow. His last patient, it seemed, had been a cheerful woman who was so grossly overweight that when she lay on his examination couch, he said, quite a lot of her flopped over the side. So much so that during the examination he'd had to ask her, "Do you mind just putting your hand down and lifting your buttock up?" Which she did. Later, when the examination was over and she was getting dressed, she started to giggle. And when the giggling showed no sign of drying up, the GP said, "Come on now, share the joke." "Well, you know, doctor," said the woman, "I've been a married woman all these years, and I never knew until this evening that I had a buttercup."
And Mike will be back in full form, buttercups and all, next month.
It's a metaphor.
What is?
Cushions the fall, as in antihypertensive Motens cushions the fall.
A metaphor?
Yes. A figure of speech in which a word or phrase is applied to an object or action that it does not literally denote in order to imply a resemblance.
Well, what does that mean then?
It means that antihypertensive Motens reduces blood pressure gradually, not rapidly. So it actually cushions the fall.
Oh, so it does that metaphorically?
No, really.
But you just said...
Never mind.
Dearly Dr. Bods, for asthma types ideally want it high topic anti-flam work down the airy passage and neglo steroid sides from the swallowed down, that may keeply the asthma control ho and provide reassurance for the Dr. Bod.
Flixotide fluticasone propionate, designed to be different.
That's exactifying what I just announcerated. Flixotide, designed to be different. Oh yes.
New Cedex, an antibiotic with all-round advantages.
Well, I have to confess to some disappointment this month. None of you got the correct answer to our last quiz question. So, to set your minds at rest, the virus which causes myxomatosis is named after G. Sanarelli, an Italian bacteriologist. But in true lottery style, we're raising the stakes for next month's competition and carrying over the £50 prize money, so that if you get the answer to this next question, you'll win no less than £100. So, for £100, what is milkman disease or syndrome? So, fax or phone your answer any time to 0171 482 2218, and the best of British to you. That's all for now. Next month, Audio Monitor unravels the problems facing the profession over re-accreditation. And Dr. Peter Stott explores the use of fibre in irritable bowel syndrome. From me, Katie Whittaker, and Audio Monitor, goodbye.